Everybody, I'm Dr. Srishti Shankar, Senior Lecturer, Department of Periodontology, and today I'll be covering the topic cementum. So, by definition, cementum is the calcified avascular mesenchymal tissue that forms the outer covering of the anatomic root. It is of two types, acellular, which is also called the primary, and cellular, which is also called the secondary cementum. So, acellular cementum is the first to be formed and covers approximately the cervical third or half of the root. It does not contain any cells and thickness ranges from 30 to 230 angstroms. Sharpie's fibers comprise most of the structure. Cellular cementum is formed after the tooth reaches the occlusal plane, and it is more irregular and contains cells which are called the cementocytes in individual spaces, that is lacunae, that communicate with each other through a system of anastomosing canaliculi. It is less calcified than the acellular type, and Sharpie's fibers occupy a smaller portion of cellular cementum and are separated by other fibers that are arranged either parallel to the root surface or at random. Sharpie's fibers may be completely or partially calcified or have a central uncalcified core surrounded by a calcified border. Both acellular cementum and cellular cementum are arranged in lamellae, which are separated by incremental lines parallel to the long axis of the root. These lines represent rest periods in cementum formation. So what are the sources of the collagen fibers? So Sharpie's fibers, which are also called the extrinsic fibers, and fibers that belong to cementum matrix, which are known as the intrinsic fibers. So organic matrix is composed of two types of collagen, type 1 collagen, which forms the 90% of the organic matrix, and type 3 collagen, which forms the 5%. Inorganic content of cementum, which is the hydroxyapatite, is 45% to 50%, which is less than that of bone, enamel, or dentine. Okay, so bone has 65%, enamel has 97%, and dentine has 70% of hydroxyapatite, whereas cementum has 45 to 50%. So now Schroeder classified cementum based on the type of fibers and cells that cementum has. So the first is acellular afibrillar cementum, acellular extrinsic fiber cementum, cellular mixed stratified cementum, cellular intrinsic fiber cementum, and intermediate cementum. So like I explained before, the types of cells and fibers which cementum has, based on that composition, Schroeder has classified cementum into these 5 types. So now cementum has certain adhesion proteins. So the first is bone sialoprotein and osteopontin. So as the name suggests, adhesion, so it helps in adhesion, but each protein helps a different kind of cell in adhesion. So bone sialoprotein and osteopontin, they play a major role in differentiation of cementoblast progenitor cells to cementoblasts. Then there is osteonectin. Then there is cementum attachment protein. It promotes adhesion and spreading of the mesenchymal cell types, and cementum derived growth factor, which enhances the proliferation of gingival fibroblasts and PDL cells. So permeability of cementum. So it has been seen that in very young animals, cellular and acellular cementum are very permeable and permit the diffusion of dyes from the pulp and external root surface. In cellular cementum, the canaliculi in some areas are contiguous with the dentinal tubule, and the permeability of cementum diminishes with age. What is the cemento-enamel junction, which we also refer to as CEJ clinically when you are seeing a case? So cementum and enamel, when they fail to meet, is type A, and it is generally found in 5 to 10% of the population. Edge-to-edge butt joint, which is also referred to as the butt joint, is generally seen in 30%, type B if you can see in the diagram, and cementum overlaps the enamel in type C, which is most commonly found and has been seen in 60 to 65% of the cases. So what is the thickness of the cementum? Now as it is a tissue, it needs to have a thickness. So on the coronal half of the root, it varies from 16 to 60 angstroms, or about the thickness of a hair. It attains its greatest thickness up to 150 to 200 angstroms in the apical third and in the furcation area. So average thickness of 95 angstroms at age 20 and 215 angstroms at age 60 has been reported. So by this data we can see that as the age progresses of the person, the thickness of the cementum also increases. Then what are the various diseases that can be found in cementum? So first is hypercementosis or cementum hyperplasia. So it refers to a prominent thickening of the cementum. It may be localized or generalized, and it occurs as a generalized thickening of cementum with nodular enlargement of the apical third of the root. It also appears in the form of spike-like excrescences, which are called cemental spikes, created by either the coalescence of cementicles that adhere to the root or the calcification of periodontal fibers at the sites of insertion into the cementum. So what is the cause of this cemental hyperplasia? So it basically happens because in teeth without antagonists, which doesn't have a teeth next to it, up or opposite to it. Okay, so in teeth without antagonists, hypercementosis is interpreted as an effort to keep pace with excessive tooth eruption. So in teeth subject to low-grade periapical irritation arising from pulp disease, it is considered compensation for the destroyed fibrous attachment to the tooth. Hypercementosis of the entire dentition may occur in patients with Paget's disease. Cementum resorption and repair, like any other tissue, cementum also resorbs and repairs itself. So it primary teeth, they undergo physiologic resorption. Permanent teeth do not. So cementum resorption may be caused by local factors, systemic factors, or it may be idiopathic, meaning it has no specific reason. So the reasons can be trauma from occlusion, orthodontic movement, cysts and tumors, embedded teeth, calcium deficiency, hypothyroidism, and like we discussed, Paget's disease. So what is the etiology of the resorption? So it may be caused by local or systemic causes, like I said, and we discuss. So systemic conditions can also be hereditary fibrous or osteodystrophy. Local conditions can also be teeth without functional antagonists, periapical disease, periodontal disease, etc. So basically, bay-like concavities in the root surface are formed, and multinucleated giant cells and large mononuclear macrophages are generally found adjacent to cementum undergoing active resorption. The resorptive process may extend into the underlying dentine and even into the pulp, but it is usually painless. So, cementum resorption is not necessarily continuous and may alternate with periods of repair and deposition of new cementum. So, the newly formed cementum is demarcated from the root by a deeply staining irregular line, which we call as the reversal line, and it delineates the border of the previous resorption. Cementum repair can occur in devitalized as well as in vital teeth. So here you can see that the resorption of cementum and dentine is shown. So if you see that the scalloped resorption in front of the dentine, which is marked as D, and the cementum is darkly stained band at the upper and lower right, which is this is the periodontal ligament, this is the dentine, and here X has been marked as the multinuclear osteoclast C. Okay. Then comes ankylosis. So fusion of the cementum and alveolar bone with obliteration of the periodontal ligament is termed as ankylosis. And ankylosis occurs in teeth with cemental resorption, which suggests that it may represent a form of abnormal repair. So it may also occur after chronic periapical inflammation, tooth replantation, and occlusal trauma and around embedded teeth. Ankylosis results in resorption of the root and its gradual replacement by bone tissue. For this reason, reimplanted teeth that ankylose will lose their roots after 4 to 5 years and exfoliate. So, when titanium implants are placed in the jaw, healing results in bone formed in direct apposition to the implant without any intervening connective tissue. So, this may also be interpreted as a form of ankylosis. And because resorption of the metallic implant cannot occur, the implant remains indefinitely ankylosed to the bone. Also, a true periodontal pocket will not form because apical proliferation of the epithelium along the root, a key element of pocket formation, is not possible owing to the ankylosis. Finally, exposure of cementum to the oral environment. So cementum becomes exposed to the oral environment in case of gingival recession and as a consequence of loss of attachment and pocket formation. So in that case, cementum is, as it is sufficiently permeable, as we discussed, to be penetrated in these cases by organic substances, inorganic ions, and bacteria. So bacterial invasion of the cementum occurs commonly in periodontal disease, and caries of the cementum may also occur. So to conclude, cementum is an integral part of the periodontium. Therefore, learning about its features in health can help us determine abnormality during a disease, and a treatment can be planned accordingly. Hope this lecture was helpful. Thank you.